Genomic testing is our sort of new area that's helping us determine which patients need what therapy within the broad classification of chemotherapy and hormone therapy. To understand that benefit, you really need to understand predictive and prognostic factors. So prognostic factors are those factors that we think about helping us understand when you stand here today with a new diagnosis, what's your risk of recurrence, what's your risk of death. What we really want to know from those prognostic factors is what is your risk of invasive recurrence and what is your risk of distant recurrence. Those are prognostic factors. Predictive factors are those that predict the benefit from specific therapies. We've had a lot of trouble with predictive factors. Right now we can predict to some degree the benefit or lack of benefit from chemotherapy added to hormone therapy for early stage hormone receptor positive breast cancer. We can predict a little bit about the benefits of hormone therapy, but not a lot. I mean, it's emerging data, and particularly there is some help in a little bit of data that we might be able to predict longer term hormone therapy benefit, but not definitive. But there's also a lot of overlap between these predictive and prognostic factors. So for example, hormone receptors are prognostic. They also predict benefit from hormone therapy. And grade is prognostic, and it also predicts benefit potentially from chemotherapy. HER2 predicts benefit from trastuzumab and to some degree prognosis, but now it's actually, less of a prognostic factor, because if you use trastuzumab, patients do very well. I suppose that gives them a good prognosis, but it's actually kind of interesting that when you looked at MA17R that the patients did so well with a 91 or 95% disease-free survival so far out. You pick patients who haven't recurred, but clearly you could look at that population of patients and look at those prognostic factors quite well. We really want to understand who's at risk for late recurrence. We've talked a lot about the clinicopathologic factors that seem to play a big role in predicting, using predictive factor here, but predicting the prognosis of patients or predicting the risk of late recurrence. But they aren't good enough, because some women will be cured, and then we all see women who had stage 1 breast cancer who have a 10 or 12 or 14-year recurrence. So it would be nice to have a genomic test that would help us predict risk for late recurrence. And there's been some data that suggests that a couple of tests have that potential ability, but none of it's perfect yet. One of the problems is that it's always a subset of patients who have tumor available for testing. And then you have to have long-term outcome information on all of those patients. 2 tests have actually looked at this in a variety of settings. So one, the Prosigna test, has looked at the data in patients who have, it's called the Prosigna risk of recurrence test, has looked at data in patients who were on the Austrian breast cancer trials and suggested that they may be able to tell differences in risk of recurrence. The breast cancer index, though, had the benefit of being able to look at a subset of samples in patients enrolled on MA17. And that actually is really fascinating data. To me, that's the best data that suggests that a genomic test will be able to potentially tell us who's at risk for late recurrence, but more importantly, who would benefit from hormone therapy. So in this subset of patients, they showed that if you were high risk by the breast cancer index, you had a higher risk of recurrence. And if you looked at the patients treated with letrozole, the patients who had a higher risk seemed to have less recurrence if they received letrozole versus placebo. Now again, this is a subset of patients, so future data from ongoing and completed trials, particularly data from the ATOM trial that they are hoping to have in the near future, I think will help us a lot in understanding the benefit of those genomic tests. But there is some early data that we could use cautiously in patients for whom we're on the fence. The breast cancer index is an interesting test because, again, I think it has the best data in terms of predicting those who might benefit from ongoing hormone therapy, although the data is a selected small group of patients from MA17, so we have to be cautious about that. it doesn't matter when you do the test. You could do the test when a patient first comes in, or you could do the test at 5 years, and I would be probably most likely to do the test later out. So, and the tumor's sitting there, nothing's happened to it, and the data has been obtained from tumors that were stored in paraffin for a fairly long period of time. So I think that that's okay. Normally, it might not be advantageous to know that information up front just because it might be overwhelming to the patient. And I don't know that that's going to change what you do up front necessarily. There is some data that the breast cancer index could be used up front, but I've tended to use some of the other genomic tests simply because there's a little more data and they came out first. So have I used breast cancer index in my population of patients? In our clinic, we started to, especially since MA17R, started to use the test in women who fall into this sort of intermediate, risk. I'm on the fence about extending adjuvant hormone therapy or not. I've had a couple of women even inquire. So I've sent the test in a few women, as have my colleagues. I do expect, however, that my use of the test may increase over time depending on the data from the NSABP B42 trial, because I think that the balance of risk toxicity versus benefit is so incredibly important for our patients. And even though those quality of life measures didn't show any difference, I have a hard time believing that it's really the case. If you look at the quality of life from text and soft, it also looks like quality of life was relatively similar, whether you got ovarian suppression or not, whether you took an AI versus tamoxifen. And it's just not true in clinical practice. So it may be that our quality of life tools can't really pick up that sort of finesse of difference that women see, that it's very hard to get that reported in a meaningful way in our current tools. There are groups of patients, as we've discussed, who might benefit from extending adjuvant hormone therapy, and then there are groups of patients who we know we don't need to do that. So tiny cancer, low grade, no extended adjuvant hormone therapy. Big cancer, lots of tumor in nodes, high risk, we're going to extend adjuvant hormone therapy. But then there's this big group in the middle that you just really don't know. Maybe a T2 tumor, maybe one node positive. You're on the fence. Should you recommend they take hormone therapy for longer or not? And that's the group of patients where we most need a test to try and help us differentiate who's more likely to benefit versus not.
So as far as patients who will be candidates for molecular analysis of their cancer to determine the risk of late recurrence, I think overall most of us tend to think about extending therapy in patients who we think are at higher risk, so patients with node-positive breast cancer, for example. I think if you have somebody with a node-negative breast cancer, it's still, I think, very worth considering doing some kind of molecular testing to see if you can estimate whether they have a significant risk of recurrence years 5 to 10. So I have to say, I think overall, for most patients, both node negative and certainly node positive, I would consider ordering one of those molecular assays to determine whether they're going to benefit from more treatment or not. The problem is the assays I think that we have right now need further validation before we can kind of just use it on every patient. The other thing I think to keep in mind is that if you have a patient who perhaps had a lot of lymph nodes positive, who wants to stop the endocrine therapy, I think using something like the breast cancer index to tell them their risk years 5 to 10 would be useful in terms of trying to keep them on the medication, and certainly I've done that before as well. I think what's a little bit less clear is whether you have somebody that's at high risk because they have node positive disease, but comes back with one of the assays showing that they have a very low risk of recurrence years 5 to 10, whether we're comfortable really accepting that data and taking them off the medication at that time point. So I think we'll get more data, but at this point I think the breast cancer index probably would be the one that would give you the most information in that setting.